Thank you for joining us for such an important topic, human rights and COVID-19, how human rights helps us understand the pandemic and our responses to it. My name is Colleen Opal. I'm the program coordinator at the University of Iowa Center for Human Rights. During this 1-hour presentation, we will explore how human rights provides a useful framework for examining the COVID-19 crisis, as well as the major human rights considerations in the responses to it from the perspectives of public health, legal, and public policy professionals. We will begin with 10 to 15 minutes for each panelist, followed by a Q&A. You can type in questions throughout the presentations, but we will hold them until after each of the panelists has presented. Our panelists today are Dr. Brian Farrell. Brian is the Associate Director of the UI Center for Human Rights and Lecturer of International Law, Criminal Law, and Human Rights courses, and the author of numerous publications on those topics. In addition, he is the Director for the UI Citizen Lawyer Program. Brian received his JD from the UI College of Law and earned his LLM and PhD in International Human Rights Law from the National University of Ireland, Galway. Dr. Peter Damiano. Pete is the director of the UI Public Policy Center and a professor in the UI Department of Preventative and Community Dentistry. He is a health sciences researcher studying healthcare reform, health insurance coverage, health disparities, and healthcare for underserved populations. Pete shares research findings through the Public Policy Center talks and symposia to help policymakers and the public understand the nuances of challenging policy issues. He is a graduate of the UI College of Dentistry and received his Master of Public Health from UCLA. Dr. Rima Fifi. Rima is a professor and the interim head of the Community and Behavioral Health Department in the UI College of Public Health. As a public health researcher and practitioner, Rima applies community-engaged research and cultural humility to equalize power, voice, and self-determination of marginalized communities, engages multiple disciplines to widen the perspectives on any issue, and emphasizes knowledge transfer of research to practice and policy. She received her Master of Public Health from UNC Chapel Hill and PhD in Health Services Research from St. Louis University. And now I will pass it off to Dr. Brian Farrell.
Thanks, Colleen. Welcome, everyone. I just wanted to explain the genesis for this panel. We at the center had been talking about how to respond to the pandemic and to do a program along these lines. And we realized that we see human rights as a useful framework for us in understanding both the impacts of the pandemic and for examining our responses and the implications of those responses. And so my plan here today is to briefly explain what human rights are, suggest their relevance to the pandemic and to the response, and then briefly discuss some specific legal issues related to emergency powers. So to start, what are human rights? They're broadly described as rights that are inherent to all people or to groups simply based on their being human, regardless of nationality, regardless of their location. They are considered to be universal. There is rich discussion on the theoretical and historical bases for the existence of these rights. Having said that, I'm going to give you kind of a simplified version of how these rights were defined and how the international human rights system was established. And really, it was a post-World War II occurrence as a response to the atrocities of that war and to create the foundation for a peace and secure future for the world. The core text for international human rights is the Universal Declaration of Human Rights. You see a photo of that here. And that was drafted by the UN Human Rights Commission in the late 1940s under the leadership of the Commission's chair, Eleanor Roosevelt. The declaration was adopted by the UN General Assembly in 1948. The declaration was an aspirational statement. Think along the lines of the US Declaration of Independence. that tried to state what the basic rights are that all people should enjoy in a relatively broad sense. It was followed about 20 years later by two other major international treaties, which articulate these rights in greater detail. Those are the International Covenant on Civil and Political Rights and the International Covenant on Economic, Social, and Cultural Rights. And together, these three documents make up what we call the International Bill of Rights. Without going into a lot of detail, it's just, again, important to note that there are many very valid critiques that the rights contained in these instruments, as well as the system itself, does reflect Western and state-focused perspectives. So I'm cognizant of that. At the same time, we're not going to go into a lengthy discussion about the limitations or weaknesses of human rights. The International Bill of Rights encompasses a broad range of rights that go beyond the basic freedoms that we tend to be used to in Western constitutional systems, and they include positive rights related to the basic needs of all people and the full development of all people, what President Franklin Roosevelt famously described as freedom from want. And so human rights include familiar guarantees such as the right to equality, right to liberty, freedom of speech, prohibition against torture, and democratic participation, but also extends to things such as the right to work, the right to an adequate standard of living, the right to education, the right to physical and mental health, and to the rights of groups. And these rights, this panoply of rights, is viewed as interconnected and interdependent. In other words, there's the sense that we don't prioritize rights, but that we view them as complementary and important to supporting each other. And I think that this background, as well as the nature of the human rights system, make it particularly useful for us at this moment as we face a global pandemic and as we craft governmental and societal responses that implicate not just individual and public health, but so many other aspects of our lives and of our world. The human rights system was born relatively recently from a time of crisis with the goal of building a better world system with broad respect for the rights of everyone, everywhere. And so some of the features of the system that I think are particularly useful, particularly relevant to us now, are the fact that it's intended to be a global system. And that it does not depend on your citizenship. These rights don't depend on where you are. They are envisioned as rights for all of us everywhere. And I think that that's particularly important, recognizing the scope and implications of a global pandemic. Another aspect of these rights that I think is important is that we don't view these rights as being in competition. We don't view ourselves as trying to prioritize one over the other, but instead that really what we're trying to do is maximize enjoyment of all of these rights. And with that in mind, I think that international human rights is important in recognizing economic and social rights as essential for all people. And additionally, international human rights provides us with mechanisms to think about how we deal with emergencies while avoiding some of the pitfalls of the past. So I want to highlight the article of the Covenant on Economic, Social, and Cultural Rights that deals specifically with health. So this is Article 12 of the Covenant on Economic, Social, and Cultural Rights. And you see here that there's a recognition of the right of everyone to enjoy the highest attributable or highest attainable standard of health, but also obligation on states, that states need to take steps to realize this right. And that includes both the prevention, treatment, and control of epidemics and creation of conditions to allow for medical services, for healthcare, essentially. And so this is what international human rights law, sort of the specific provision that talks about healthcare in great detail. But again, while pursuing this goal, we want to simultaneously maintain and maximize respect for these other interdependent rights. And so human rights, in a way, provides, to me, sort of this checklist of us to think about various considerations and how potentially to balance them while maximizing respect for all of these rights. And so as we think about this right to individual health, this right to public health, I think it's important for us to consider some of the other rights that might also be very relevant as we craft responses. And just a few that kind of come to mind to me immediately. One is the very important right to equality and non-discrimination. This is actually something that is referred to as a principle in international human rights law because it underlies and permeates all aspects of the system, that we want to ensure equality and we want to ensure non-discrimination. And this also extends to disparate impacts. So we want to be aware of disproportionate impacts on particular populations in terms of responses. But also, in addition to equality, in addition to this right to health, we want to think about these sort of co-equal and interdependent rights, such as the right to work, the right to education, rights to personal safety and liberty, adequate standard of living, the right of freedom of movement, respect for family, respect for privacy, political participation, such as voting, and rights to Social Security. And I'm sure you can imagine that any of these individual topics we could spend hours talking about. But my point is that this framework, the International Human Rights Framework, might help us think about the impact of, for example, a shelter-in-place order on a person experiencing homelessness or a domestic violence survival. It might cause us to think about the struggle of someone who's been laid off to feed their family, or the potential for disproportionate impacts on marginalized communities. And I think that the human rights framework encourages us to think about these as connected and interdependent. Of course, those of you familiar with the system realize that there are limits on enforceability in the United States, but nonetheless, I think that the framework really can help us conceptualize a cohesive and balanced approach to the pandemic. And now I mentioned earlier the accommodation of emergencies. How do we deal with and how do we allow governments to deal with emergencies? The human rights framework recognizes the potential for emergencies that might require the temporary suspension of certain rights, expansive government powers, or changes in the way that governments function. But it requires that this happens in a structured and regulated way. And under, again, the International Human Rights Framework, it's important that emergencies are publicly declared, that measures be taken to strictly tailor responses to the exigencies of the situation, and that any emergency powers be used for a defined period of time. And the goal is to provide the state with flexible and broad powers, while at the same time avoiding a slippery slope of the continued use of emergency powers in a way that might lead to eventual abuse. In the United States, primary legal authority for response to a public health emergency falls to states. Powers such as quarantine are part of the police powers that are generally reserved to states under the US Constitution. So when we talk about shelter in place or quarantine here in Iowa, we are primarily talking about state law. So I thought I'd provide just a brief overview of those powers. On March 17th, Governor Reynolds issued a proclamation that recognized a state of public health disaster emergency throughout the state of Iowa. And it appears there have been 6 additional emergency proclamations related to COVID-19. And you might recall that that first proclamation on St. Patrick's Day closed restaurants, bars, theaters, and other social establishments, and also prohibited gatherings of more than 10 people. But it went beyond that. It also addressed many regulatory issues. For example, as I was looking over this, I discovered that right now in Iowa, I can drive with an expired license for up to 60 days, and stores do not have to accept bottle deposit refunds at the moment. Subsequent orders suspended elective surgery, suspended evictions, but again, also dealt with a lot of more mundane aspects of the regulatory actions of the states. And all of these actions were taken pursuant to the governor's powers under Chapter 29C of the Iowa Code and the public health disaster provisions of Chapter 135. And these powers are really quite broad. The statute requires that there be a defined duration for any emergency, and that can be rescinded by the governor or by the legislature. It can be rescinded by the full legislature if it's in session, or if the legislature is not in session, such as now, by the Legislative Council, which is a bipartisan group of about 20 legislative leaders. And so while these powers are broad, there are also checks and accountability in terms of the exercise of these emergency powers. In addition to the governor's power to declare an emergency, the Iowa Department of Public Health has the power to order quarantine and isolation under Chapter 139A of the Iowa Code. Quarantine refers to the confinement of a person who's been exposed to a disease during the incubation period. Isolation refers to the confinement of a person who's exhibiting symptoms for a period of the communicability. So quarantine is sort of the preventative, you've been exposed, we want to keep you in isolation. Isolation, on the other hand, is someone who is already sick and exhibiting symptoms. Again, these are defined situations, but once those defined situations are met, the powers are somewhat broad in terms of the State Department of Public Health's authority to make orders regarding individuals or entire areas. Quarantine can be entire geographic areas, and the department can enlist law enforcement to enforce its orders. There are administrative rules that include means for review, both to the department itself and in front of Iowa's courts. So again, the powers can be viewed as somewhat broad, but there are checks and accountability does exist. And I think that these emergency powers, the powers that countries, the powers that states have to use during emergency times are important for us to understand and to think about them. We want these powers. We need them to provide government with flexibility to deal with unexpected situations. And at the same time, the existence of limits and the existence of accountability mechanisms is important to prevent misuse. Again, this is another topic that I think we could spend an hour or more on. But as with the human rights system itself, my goal is just to scratch the surface and sort of identify these issues for you. So at this point, I am going to pass things over to Pete.
All right, thank you, Brian. That was a very nice introduction to the whole idea of human rights and public health. And so what I'm going to be talking about today is focusing on sort of a two-part aspect of this. One is the healthcare delivery system aspect, and some of that is the public health. And just starting with, is generally understood in the United States, we have not established a right to healthcare. But often when we get into these discussions, we sort of combine the issue of healthcare and healthcare delivery and the issue of health. And those things are actually very, they're related, but they're different. And I'd like to sort of tease that out, talk a little bit about what the response has been like, specifically on some of the bills and other policy changes that have gone on relative to these things because of the COVID-19 pandemic. And then also give something to think about, that in the long run, are these things that are going to change? Or are these things that will revert right back to where we were before on some of these things? So, number one is really, have we really learned that we're all in this together, and that the health and well-being of our neighbors and other citizens across the country and across the world do impact us in a way that we really do want to put some resources into that? And then the second part is, do we really believe in public health, population-based healthcare and prevention? And will we build any kind of a lasting infrastructure and put resources in consistently over a long period of time? Some of you might have heard about the governor's press conference this morning, and there are 97 new positive cases that have been tested. And while it's important to track those, I think many of you understand the whole idea that we don't have a good sense of what the denominator really is, because we lost those first couple of months to really get a baseline and to know what's going on. So while the testing is somewhat important when we're talking about both clinical care and public health, we really are going to be focusing on them as if almost everyone is positive at the moment, dealing with symptoms, and then hopefully thinking ahead to where we go from here. When we passed the Affordable Care Act in 2010, there were components of that affected the healthcare delivery system and healthcare financing. One of those that we really think about most frequently is the additional of health insurance coverage to about 20 million people as a result of the various components of the ACA. And although we've rescinded a few aspects of that, we still have gained probably 18 million people or so who had health insurance coverage. But we're seeing with all the people that are being laid off and losing their jobs that the number of the uninsured is growing significantly, and that's going to be placing a burden that some of which will be being dealt with some of the changes that have been made in policies and laws, and some of them maybe not so much. But even without those changes, we still had 28 million people who were uninsured across the country coming into this whole situation, and another 25 or 30 million people who are underinsured. And so those are often are people who think they've got pretty good health insurance coverage, but when they come up to the point of actually needing it or having some sort of a crisis, turns out they don't. That's one of the reasons the United States is very different than other parts of the world in terms of a lot of bankruptcies are related to healthcare costs and the challenges that families can face because of high healthcare costs. That's something that is somewhat unique to our country. And we'll sort of have to see where those things are going to be going as we're moving beyond this current crisis. But what's often lost in this is the whole issue between health and healthcare, as I was talking about. And this is where I think it becomes a really important human right issue. While on campaigns and healthcare, whether it's Medicare for all or a lot of other kinds of things that we hear discussions as if that's some sort of having a right to healthcare, that's really, and while it can be a good thing, what we're talking about is a right to healthcare financing and a right to health insurance. Just having health insurance coverage does not necessarily mean you have a right to health. And that doesn't mean whether it's public insurance or private insurance or the quality of that insurance. But if you think about what are all of the things that determine whether you are healthy yourself on a regular basis, outside of times when you have some sort of a healthcare situation or a healthcare crisis like we're going under right now. But for the most part, our health status really comes down to about 50% related to behavioral factors that are within our control. And these are things that I think you can, things come easily to mind, whether it's exercise, nutrition, substance use, wearing a seatbelt, all of these things that are within our control that then do affect whether it's chronic or acute health situations. About 20% of our health status is due to environmental factors, which sometimes can be a human rights issue because often people with less resources are going to be in situations where the environmental factors, whether it's air quality, water quality, or other types of pollution, for example, might be more of a contaminant, more contaminated because that area is cheaper, for example, to live. About 20% is our genetics, but only really about 10% of our total health status is related to the healthcare delivery system. And I think at times we get overemphasized on that. But in the United States, we put about 90% of our spending on the healthcare delivery system and much less on social services and other things, which I think brings in that whole human rights aspect of this. And which really brings us to the whole idea of the social determinants of health. And so that's a term that can mean a lot of different things to different people, but it really are, what are those things that determine whether we are healthy or not? And I don't even like to use the term social as a part of that because I think it makes it seem sort of soft and fuzzy, and if they're not really important. But these are the things that really determine whether we're healthy or not. And that's, having wealth is a component of that. Having a good job that not only brings in income, but brings in the self-esteem that goes with that. Early childhood education, childhood experiences, as many of you know, are adverse childhood experiences, ACEs, the concept that's getting a lot of play right now, and the importance for long-term in life. Social supports, housing is one of those things, food security, all of those that are really important, of which healthcare is one of those. But so many of these other things that we don't think of as necessarily being related to health when we're talking about it from a public policy perspective, but really are, and I think in this type of a crisis, become critically important for us to really think through what are we doing about it now, but what are we going to do when we get through on the other side of this? Are we going to continue to really see that those things are important or not? You know, in terms of some of our responses, we've been doing some things related to the healthcare delivery system. So one of the things that is a real positive that came out of the Affordable Care Act is that many people who have lost their jobs now can enroll in the health insurance marketplace to get subsidized private insurance, or they might be able to get in Medicaid and get public insurance. And because of the Medicaid expansion, of which I was one of the states that did that, single adults up to 133% of poverty become eligible for Medicaid. In addition, the State Department of Human Services has been applying for a whole series of different waivers to try to make it easier for people to get health insurance coverage and other payments for things that might be important to keep going through this time period. And they have a page on the Iowa DHS website if anyone is interested and can look at all the things that are going on. It really is a very dynamic situation and fluid, and especially as some of these laws that were passed are being interpreted. So you really have to check back and see where something is for your particular situation, but something that is worth looking into. There are also some things there that affect the determinants of health, such as increased benefits for food assistance. Sometimes some places are making it easier for people to apply. Some of the restrictions that have been put in the last few years, work requirements and some other things are being relaxed. And so it's a really important thing to look at that. But there still are a lot of challenges in how we're going to pay for these things right now, let alone even in the long term. There was a report that came out yesterday that talked about, from the Kaiser Family Foundation, that the cost of treating the uninsured for COVID costs could be anywhere from $14 to $41 billion. In the CARES bill that went through at the federal level, there was about $100 billion set aside for hospitals and other types of healthcare related costs. Well, right there, that would be a huge component of that. And they're estimating that's about 2 to 7% of the uninsured that would be hospitalized. So that's in the neighborhood of 700,000 to 2 million people. You know, again, we're in a very fluid situation. We don't know anything yet about the flattening of the curve, and it's obviously popping up at different levels in different parts of the country. And so that's something just to sort of keep an eye on. What are the costs are going to be? How are we going to take care of these things now? But then also what happens when we get through this? If we decide that we do want to make sure that people have health insurance coverage because it's better for all of us, are we all in this together? There's going to be obviously additional cost to that. There will also be some cost savings, because when there are these uncompensated costs to the system, whether it's hospital costs or physician costs or other kinds of things, you are going to see situations where those are getting passed along to the rest of us. So the states that didn't do the Medicaid expansion, for example, their other citizens, not the uninsured, but those with insurance, are paying more because they're not taking the federal money, which would have taken care of most of the costs for those people who were uninsured and eligible for the Medicaid expansion. So these are the things, are we really going to be thinking about that we are in this together, and we do want to do things that help others, and with the idea that it will benefit us ourselves. Medicare, for example, one of the largest payers for people who are over 65 and people with disabilities, for them alone, the hospitalization costs related to COVID is being estimated between $40 and $115 billion to cover these costs, and they're increasing their reimbursement 20% over what they would have before. And so again, very significant. There's also something, I'm not getting into a lot of this, but there's been a change in the payment approach that we're taking with our healthcare system toward what's called value-based purchasing, and trying to put more of the risk on the healthcare providers to try to get the system to be more efficient. Well, that was never designed to be able to handle these huge influx of costs that are coming. And so how any kind of system that's going to be putting more of the burden on the healthcare providers with all of these COVID costs, even though there's some of this reimbursed, will it be entirely, and how is that going to disrupt this all value-based purchasing idea? On housing, we have been delaying some of the evictions, but that might be for a month or two. So again, are we really going to believe that those determinants of health are a human right? And we do believe in housing should be a component of that. Same with food security. Are we really going to do things longer term to be able to take care of it? We've been ramping up the medical care side, as you've been hearing, with things like respirators, N95 masks, other protective equipment. But we have been noticing, even with that, we've got a shortage of healthcare providers in many cases. We know that we've had a severe shortage of mental health providers, whether it's adult care, children's care, adolescent care. And so that's going to be a key issue, obviously, with not just dealing with COVID, but all of the repercussions later. Are we going to do anything about that? And there hasn't been a lot of talk yet about the public health infrastructure. So are we going to really ramp up? It could be COVID-related things like future testing. It could be looking at antibodies and looking at who has, because as I think many of you are aware, they're now understanding that you can be positive for the COVID virus for 2 or 3 days or 4 days before you're showing symptoms. And so there are a number of people out there, or not showing them at all. So there's a lot of people out there who might be, at least for a period of time, built up antibody resistance to the COVID virus. Are we going to test for that? How do we then, can we then deploy those people into certain situations more safely? And then you're starting to hear some things about health disparities in terms of COVID specifically. There's lots of research showing health disparities related to race, ethnicity, and income, and a whole variety of urban, rural, and other things like that. There's been a couple of stories recently about communities of color being at higher risk for hospitalizations, deaths related to the COVID virus. You have to be very careful with those, because with those data, because the denominators that I've seen a number of those are statewide rather than necessarily the communities. But nevertheless, many people in those communities, because of their health disparities, have underlying chronic health conditions that's going to make them more vulnerable if they do get the COVID-19 disease. So are we going to be able to expand these things consistently afterwards? Are we going to see that housing and other determinants of health, access to good education, and even some things that you often don't see on that list but are coming up as really important, such as access to high-speed internet and technology. Schools and distance learning for K-12 are running into a lot of issues that families don't have that. And there's a lot of people that are equating that access to high-speed internet and having home technology is the equivalent to public education was back in the late 1800s. And so are we really going to make a move in that direction? So are we dealing with these things now? And how are we going to deal with those in the future? I think are going to be important policy issues for all of us to consider. So with that, I'm going to turn it over to Dr. Remy Afifi, who is the interim department head in the Department of Community Behavioral Health in the University of Iowa College of Public Health.
Hi, everyone, and thanks, Brian and Pete, for setting all this up. And I hope to build on what both Brian and Pete talked about. I'm very happy to be part of this, and thank you for joining us. So I'm going to be making a few points related to sort of COVID-19 and the human rights implications of the response to COVID-19. So as has become evident, public health is sort of getting a lot of attention with COVID-19, much more, I think, than we were getting previously. So public health approaches and methods and tools have received a lot of attention as a result of COVID-19. But I think what has been less said is the core public health values that drives all of our work in public health. And those are values of equity and social justice. And so that's where I'm going to focus my remarks, because those values are very much linked to the rights framework that, that Brian presented as well. So I'm going to focus on two main issues. The first one is sort of around the definition of health. So I think I need to highlight that when people use the word health, they often mean physical health. Although as far back as 1948, the World Health Organization defined health as, and I quote here, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. But generally, we still use, when we use the term health, we mean physical health. So this has affected the response to COVID-19 in multiple ways, and perhaps most importantly, because we've tended to sideline other aspects of this broader health definition, including mental health, which I think is a very significant aspect of our well-being, and very much relevant and present in the COVID-19 crisis. So with that, I further want to unpack the term mental health because it is, as I said, so relevant to how we've responded to the COVID-19 crisis. So when people use the term mental health, they often actually mean mental illness. But mental health, just like physical health, exists on a continuum where one side of that continuum might be complete mental well-being, which is probably quite rare, and the other side is complete mental ill-being, which is also quite rare, I think. So each of us goes back and forth along this continuum every day, sometimes every hour. And understanding that mental health applies to all of us every day can decrease the stigma that is automatically associated with the term when we speak of it, and open up opportunities for dialogue and response. And this is, I think, particularly important because COVID-19 has affected mental well-being in such significant ways, and I think will continue to do so as we move forward. And mental health is stigmatized so much that it ends up being one of those issues that can lead to some violations of rights. The second main issue that I wanted to talk about is this aspect of a focus on individual risk factors rather than the social and structural risk factors that Pete was mentioning in his presentation as well. So for many centuries, actually, we've known that health is much more than biology, exactly as Pete defined. And in fact, our individual and population health is determined to a much greater extent by social, economic, and political conditions than by our biology or genetics. In 2008, the WHO's Commission on the Social Determinants of Health released a report that sort of placed social and structural determinants of health very central in the discussion or discourse around public health. And the Centers of Disease Control and Prevention defines the social determinants of health in this way, and I quote, "The social determinants of health are the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness." They further state that these circumstances are shaped by a wider set of forces: economics, social policies, and politics. And I think Pete did a really good job of giving you some examples of those social determinants of health and some of the social policies that have been enacted, particularly in relation to COVID-19, but that we need to think about in a broader perspective. There is increasing evidence in the US and across the world that marginalized groups who have experienced historical and current oppression have greater mortality, a heavier burden of illness, and lower quality of life than privileged groups for almost any health outcome, actually irrespective of health behaviors. And you know, Pete mentioned that health behaviors are a core component of our well-being, but health behaviors are also affected by those social, economic, and political circumstances. So yes, the marginalized groups who have experienced historical or current oppression have greater mortality, a heavier burden of illness, and lower quality of life than privileged groups for almost any health outcome. When this occurs, those differences in mortality and illness and quality of life between groups, we call that in public health a health inequity. And we define that health inequity as a difference in health status, which is unnecessary and avoidable. And the reason it's unnecessary and avoidable is because it isn't based purely on biology, it's based on social factors and therefore shouldn't be determining our health and well-being. And because they are unnecessary and avoidable, they're also considered unfair and unjust, and therefore very much linked to the human rights framework. COVID-19 has basically highlighted inequities that were already present in all societies, including in the US. So why is this relevant to COVID-19, and how has a lack of attention to these structural and social factors affected our response to COVID-19? So the attention only to physical health and basically to individual actions such as social distancing or hand washing, those types of individual behaviors, has led to recommendations that may not be applicable or adaptable to the social conditions in which many, many people find themselves. So if we take social distancing as one example, this specific recommendation has disadvantaged several groups, including any group that by function of social, economic, or political factors is not able to social distance. So that might include people in prison, it might include people living in refugee camps, it might include people living in overcrowded spaces, etc. The recommendation for social distancing has also severely increased negative health outcomes for women and children that are living in violent situations. And Pete mentioned this as well. So yesterday, the UN stated, and I quote, "It's clear that when women and girls are locked down in their homes with abusive partners, they are at much greater risk than ever before." So that we've seen an upsurge in violence, not only in one country or one region, but actually media reports are documented an increase in violence and domestic violence across the globe. The recommendation to get tested or to see a healthcare provider if you're experiencing serious symptoms and possibly be admitted has also not considered existing and historic disparities, particularly in communities of color, but also for populations of lower socioeconomic status. So access to care, of course, is very dependent on insurance. It's dependent on having a regular point of care. It's dependent on a healthcare system that's inclusive of multiple languages and that's culturally humble. So this affects, for example, the ability of refugees and immigrants to access care. It affects the ability of communities of colors to receive quality care. And recent reports that are coming out of Detroit and Milwaukee and New Orleans indicate really staggering and appalling patterns of inequitable mortality from COVID-19 for African Americans, for example. This analysis by race, by class, by ethnicity has not actually been standard yet. And so we don't know the extent of these inequitable outcomes. But history does give us a very good idea of what it will look like if we don't pay attention to this. There's many others that are disadvantaged in COVID-19 as a result of social, economic, and political conditions, including, and again, these are just some, persons with disabilities, indigenous populations, persons with prior mental health distress, and many, many more. So my take-home message around human rights and COVID-19 from a public health perspective is really, unless we keep human rights and those economic, social, and political rights front and center, unless we keep equity and social justice at the center of our analysis of and response to this particular epidemic/pandemic or any other, then we are continuing to violate human rights regularly and to create a world where, and this is from the Commission on the Social Determinants of Health, social injustice is killing people on a grand scale. I do want to say that despite the fact that it took us quite a bit, like the initial response was just physical health and was just individually focused rather than social and economic factor focused, we still do have an opportunity to do better with COVID-19, and there is emerging many responses to some of those social and political and economic inequities. But I also think we can apply some of these learnings to the next phase of mitigation. So for example, in decision-making about priorities for vaccination, we know that when vaccines first become available, and we know it's a ways off, but when they become available, they're likely to be available in smaller batches than we need. So we are going to have to make decisions about priorities. Who is identified as most at risk to get the vaccination? And I would urge that when we consider most at risk, we consider both biological most at risk, so people that have underlying conditions, health problems, older adults, people that are biologically most at risk, but also people that are socially most at risk, before we then sort of open it up to the larger population. So this would mean, of course, frontline workers would be first in line. I think that's sort of a no-brainer, but then who's next? Right? A social determinants of lens framework would suggest that In addition to those most at risk due to biological vulnerabilities, we would prioritize those most at risk as a result of social conditions. So people in prison, people in refugee camps, people with mental distress and in violent home situations, people of color and of low socioeconomic classes, and other sort of marginalized populations than that we have noted above. And I think if we disagree with that prioritization, then we're fundamentally valuing some lives over others and continuing a history of racial, ethnic, and colonial oppression. I did want to end by sharing a beautiful quote from an article that I read today by the renowned author Arundhati Roy, where he reflects on COVID-19 worldwide, but also specifically in his country of India. And I quote, he says, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it." End quote. I hope that we're all committed to fighting for equity and justice in COVID-19 and beyond. Thank you.
Thank you, Dr. Afifi. And now we will spend the rest of the hour answering your typed questions. We'll do our best to answer each one. So the first one we have here is from Caroline. She asks, is there a tension between necessary measures to identify and isolate COVID-19 cases and a robust respect for human rights? We are operating in a fluid and rapidly evolving situation, and we may not know whether China's approach to combating the virus is the best or necessary approach. But to what extent should we be prepared to relax our ordinary approach to human rights, and in the US context, constitutional safeguards, to address community spread?
I'm happy to offer some thoughts. First of all, I think that the question uses the word tension between sort of isolation and other human rights. And this is where I think that the human rights framework is useful for us to think about these as rights that support each other, rights that are interconnected. And so perhaps if we can try to avoid viewing them as competing rights, but instead mutually supporting rights, and we want to maximize them all. In other words, we don't want to sacrifice one right or one set of rights to protect another set of rights. We want to flexibly try to maximize enjoyment of all of these rights. And so, the emergency systems, the emergency mechanisms that I mentioned, they try to create a structure to allow for responses that may, at a given time, relax a state's obligations in terms of ensuring particular rights, but only to the extent needed, only for a defined period of time, and with some accountability, with some mechanisms to ensure that we minimize the potential for misuse. And again, I think that this is probably very important to recognize that if we have, these types of powers utilized, that we want them to be used in a manner that is very much contained and very much accountable. And so, yes, quarantine, shelter in place, those are orders that do restrict rights. They restrict human rights if we conceptualize of them that way. If we think about them in terms of US constitutional rights, they may implicate those rights, and we see them as necessary short-term trade-off, but again, important to, I think, attempt to limit them only to the extent necessary, and to keep these other considerations in mind. For example, the principle of equality and non-discrimination, that we don't want the burdens of, perhaps the suspension of rights to fall on particular populations, particular vulnerable populations, in a disproportionate way.
Anyone else want to add to that? No, okay. Second question here is from Sabine. They say, with the rise of hate crime rates targeting Asian Americans and Asians residing in the U.S. and the effect it has on mental health, where do we turn to frame this crisis in terms of laws, policies, etc.?
I was just going to say, to follow on with my last comment about principles of equality and non-discrimination, I think one important thing in the human rights framework to keep in mind is that contains a positive obligation on the government, not just sort of passive non-discrimination, but positive efforts to achieve that. And so that's one thing that I would mention, that I think that there is, not just people shouldn't do that, but an affirmative obligation to minimize the likelihood and to provide protection, provide redress for people who do suffer that type of injustice.
Go ahead, Rima.
I guess I would further sort of add to that I do think that the sort of the human rights documents support support this this response. I also think it's a broader aspect of how we interact as people with each other, and this idea of othering, which is, I think, very common across across the world. So in almost every interaction, you can sort of think about how we try to say that other people are different than ourselves, rather than trying to find the similarities amongst us all. And in fact, this is a good place to think about the similarities, and using a social, political, economic framework for that, I think, is very helpful, because it makes us understand that what affects us all are these sort of what the Racial Equity Institute has called the groundwater. So the things that we take in, the attitudes that we take in, just by function of the current social order, or the current political order, which of course is coming from the historic political and social order. So if we can understand how our attitudes are very much shaped by that larger system, it really does help us unpack why we may have these views of othering, and help us sort of unpack this.
Okay, we have another question here from Adrian. Will the governor ever join the other states in locking us down? Quote unquote.
I'm not going to try to speak for the Reynolds administration or state government, but I have been in communication in the last couple of days with the director of the Department of Public Health on this. And it's a really interesting question, both at a high level and then at a more granular level. And I think at a high level, Iowa's actually done a pretty good job, and was one of the earlier states in doing a lot of the things that fall under a stay-at-home or stay-in-place kind of order, with the closing of bars, restaurants, and a number of other activities, schools. When you start getting to where we are now and sort of what's left, that's where I think it's sort of interesting. You could compare where Iowa is now to many states. Minnesota is one that I've heard it compared to, that we're virtually the same in terms of what we're doing as Minnesota, even though we're not calling it a stay-in-place order. You look at what we're doing relative to Texas, and we're doing way more than a state like Texas that says they're having a stay-in-place. You look at our map, and it looks like we're doing nothing. On the other hand, could that be affecting compliance? And we just don't know. Are there some other activities that people are choosing to make their own call on? So I was talking to somebody this morning that their childcare situation was still open, where I know lots of them have closed. And if that is, one of those things that's still on a situation by situation that might be affected. And I think early on, by not doing it, you might have gotten better people buying into the whole need. The question of where we are now and what's left and where we're going, I think, is a really interesting discussion. But I don't think it's fair to say we're not doing anything, and I think most people aren't. We are doing quite a bit. But what would be left if we did a stay-in-place order compared to where we are now, and what would the implications be on the activities? And I'm not sure there's a great answer to that. It was sort of interesting. You might have seen yesterday a whole new list of things that were now closed that you could argue maybe should have been before. Malls, for example, there were. And then some ones that were sort of bizarre that they hadn't been or been pulled out for some things. And that's where at that granular level, you could really start, having a reasonable policy discussion about what should or shouldn't be as a part of the essential services, which is really what it comes down to. If you've got the stay-in-place order or not, what are you calling essential, which is varying drastically across the states. Food production, does that include hog confinement, meat processing plants and things like that, which the state attorney general said Friday night on Iowa Press would be essential in Iowa, et cetera. So those are tough calls. And then, as we've been talking about from a human rights perspective, a lot of the communities and people that are affected are those that are less able to afford some of these situations that could be more restrictive. So, it isn't just a one way or the other. I will say it doesn't make us look good, right? When you show those maps for 1 of 5 states, all those things, but you really need to, again, I think from a policy perspective, look at it more closely and really decide, okay, what's left? And are those things that are critical and should be affected?
Thank you. And there's one more question here for you, Pete. Can you explain, this is from David, can you explain a little more what you said about the increased costs to states that are not accepting Medicaid money? And that'll be our last question for now because of time.
Yeah. Sure. This is something I think it's a really interesting both political and policy question, because as many of you know, when the Medicaid expansion, the ACA, the Affordable Care Act was first put in place, it tended to be more blue-leading states that adopted the Medicaid expansion, which was a more generous coverage for single adults, and the more conservative states that didn't. Not uniformly, like Ohio, Kentucky, a few others did, even though they had Republican governors. Over time, a number of other states have seen, look, we're getting virtually at first, for the first 3 years, 100% of the costs for those people in the Medicaid expansion. And we're leaving that on the table. And they're still at over 90% that they're getting reimbursed for those people who are part of the Medicaid expansion. So the 2 big states right now are Florida and Texas that are literally leaving billions of dollars on the table, and their uncompensated care costs are much higher than in states that did the Medicaid expansion, as I mentioned earlier. And so that's a cost to all of the citizens in their state by not doing that. I actually wrote an article in the Hill publication last year on that topic, if anybody wants to find that and read about it there if you're really bored looking for something to do. The Hill is a nice policy publication that talks about issues such as this, and it's in there.
Thank you again to our panelists, Dr. Brian Farrell, Dr. Pete Damiano, and Dr. Rima Fifi, and our attendees. You can access a video recording of this webinar on the UI Center for Human Rights website and contact us at the email address listed here, uichr@uiowa.edu. Our website is there listed above. We're hoping to have some future webinars on topics related to this, and we'll keep you posted if you check our website or Facebook. All right, thank you again.
Thank you.
Thanks, everyone.